I'm Dr. Vidya Ravi, President Trichy ONG Society. Good evening to one and all who have gathered here for this wonderful webinar. I can promise you this webinar is going to be a real academic feast because we are having two doyens with us who are going to demystify the COVID-19 situations, peri-COVID-19 situation in OB/GYN practice. COVID-19 has been shaking the whole world for the past 6 months. I think you all know that. And we as OB/GYNs are confused about what to practice and what not to practice during these times. And here are the doyens to demystify this situation. And I call them doyens in this field because you will also agree that they are in this field at the end of this webinar. Now I shall welcome one of the doyens, none other than Dr. Shanta Kumari Madam. She is President-elect and she is a most charming Foxian, I can say. She needs no introduction to any crowd ever, and she is gracefully accepted to virtually be with us from the city of Charminar to the city of Rockford. I think you all know, even those who are in Trichy, if you all know, I think I should say that our country, our Tiruchirappalli district has got a lot to know about temples, the architecture, the Kaveri River, so and so. I think if Madam is really with us, we would take her around and show. Madam, I take immense pleasure and it's my honor to welcome you with a bouquet of roses. Please accept it. And we are really pleased to have you here amidst your busy schedule, Madam. You've been going and inaugurating a CME and you've been running around Kannur and Trichy. So we are so happy to have you here with us in this webinar. And unusually, Trichy is very pleasant. You can even make a visit, really, Madam. Thank you very much for being with us. And the next doyen will be the most busiest and most popular academician of Foxy, I should say. He's having back-to-back webinars day in and day out, who's none other than Dr. Niranjan Chavan. Can you hear me, sir?
Yes, I can hear you.
Okay, Dr. Niranjan Chavan, sir, I am really pleased. On behalf of Trichy ONG Society, I am really pleased, and we are all having immense pleasure and honor to invite you for this webinar. And really, your acceptance amidst your very busy schedule makes me really wonder how you can do all this in a day. I think 24 hours is not enough for them. I welcome you again with a bouquet of roses, sir. Please accept this e-bouquet as a welcome address. Thank you so much, sir, for being with us this evening and sharing your knowledge, both of you, sharing your knowledge on COVID-19 in OB/GYN practice. Thank you so much. I also welcome Dr. Aruna, who's going to be with us all the way from Hyderabad. Thank you, madam. Thank you for being with us and spending your time and sharing your knowledge with us in the Trichy ONG Society. Another person I want to introduce is Dr. Kavita Sendal, who's going to give a talk on role of low molecular weight in recurrent pregnancy loss. She needs no introduction to Trichy OG Society. She's a member of the Trichy OG Society. She was a past secretary too. And Dr. Arul Muri, a senior consultant, and she's also a member for a very long time from Trichy OG Society. She's going to be in the panel. And last but not the least, I'm going to welcome Dr. Jayam Kannan, who needs no introduction to any viewers here and there, I should say. Thank you, madam. At the last minute, you have obliged to be with us in this webinar, and please share your knowledge. I welcome you again with the e-bouquet, madam, bouquet of roses. Thank you so much to be with us here and share your knowledge, madam. So let's go. I give it on to Dr. Deepa, who will be co-moderating this session. Over to Dr. Deepa. Thank you, sir.
Vidya, before Deepa comes in, I wanted to say one hi to all the members of Trichy.
Thank you.
It's a pleasure to be. And I have to tell, Jayam madam knows, I'm not a newcomer to Trichy. My
Definitely not.
My grandmother is from Trichy. Okay.
Then it's definitely your town, madam, hometown.
It's my town. Okay. I just wanted to share this with you.
That's nice. That's very nice of you, madam. So over to Deepa. Can we go over to Deepa, madam? Yeah.
Yeah. Thank you, Vidya. I think, first of all, my heart goes out to all the people of Maharashtra, Chennai, Gujarat, and all those places where the COVID-19 cases are going up and the deaths are being reported. I think, as Dr. Vidya said, it's shaking the world. And doctors are going through a very difficult phase, I must say. They are in a state of confusion, a lot of fear. The guidelines are changing day in and day out, and they are not sure what is the right practice to be done. And I would call this period of manic depressive psychosis or whatever. Mania because it's a webinar mania, I should say, and depression is because of the COVID-19. So we are combining both today, and we are in fact having some doyens who are really experienced in this field. It's very apt that you are here with us, Dr. Niranjan, and of course Dr. Shanta Kumari madam, to share your experiences with us. I must thank ICOG for giving us one credit point today for this webinar, and my sincere thanks to Science Integra and Bharat Serum for arranging this beautiful webinar today on this evening. So I think we move on. I request Dr. Jayam Kannan, our senior consultant, who has extensively interacted with Dr. Niranjan and Dr. Shanta. She will be the most apt person to introduce formally Dr. Niranjan. Please welcome Dr. Niranjan, and madam, please proceed.
Thank you, Vidya and Deepa, for giving me this opportunity. I can't say...
Madam, you gave us this opportunity, madam.
Yes, you gave this opportunity, and as a Trichy Trioxian, I'm very happy about it. And say hello to my daughter-in-law, Shanta.
Oh. Oh. Why, madam? Daughter-in-law?
Yes, her father-in-law is from Trichy.
Oh.
So she is the daughter-in-law. So her father-in-law should be of my age or a little more, you know.
Oh.
So I look at her as my daughter.
Grandmother, madam.
Okay, anything you take. And now, Professor Niranjan Chavan, yes, he is the apt person for today's lecture, as he is the HOD of LTMM Hospital at Sion, which is catering to more than 200 cases of COVID pregnancy, which is a very significant one. His biodata runs to 5 pages, which you can see. However, he is the pillar of Mumbai society in many ways. He has been a general secretary, he has been a scientific secretary, he has also been the vice president of Mumbai society, which has got more than, I think, 3,000 members, maybe 70% of what we have in Tamil Nadu. I cannot forget him as a chairperson of the oncology committee in 2012 to 14, at which time he took a nice travel from his place down to Chennai by flight, and from Chennai to Tiruchirappalli by road. At that time, there was no national highways. I really saw him just half an hour before the program, but he lovely lecture that he gave. He has been the chair of the Academy of Global Obstetric Gynecology, chief editor of AFG Times, like another TOG. And he has been running a certificate course in BIME, LTMGH, all those things. And he has been also the managing committee member of IAGE. And he is in the editorial board of European Society of Gynecological Oncology, Italy. Nobody can forget what Italy is and the scientific output Italians are doing. His position in many places runs to a page in his biodata, and he has been awarded many prizes. The best prize that he had was with Dr. Nandita Palshekar for V-First3 last year. Before that, he had more than 17 to 18 awards to his credit. And the best award is wife, Komal Chavan, who runs equally with him for all the webinars. Academically, I will say, he is one of the strongest persons India is seeing. Yes, we know Dr. A.L. Mudaliar and others And from our side, Professor Bhaskar Rao and Niranjan is going to be marking from Mumbai. His publications has been too many. To just say a few, in this last 5 months amidst COVID and lockdown, is psychological issues in obstetrics and gynecology, cesarean delivery, and accidental hemorrhage. He has been running always on live webinars, more than 15 to his credit. Even today, it is a second webinar for him. A couple of hours ago, he was at the western coast of India, Kozhikode, and now he is at the eastern side. What more? This pillar of Mumbai is going to become the best pillar of Foxy, apart from his chairpersonship, and soon to see him decorating the days of the managing committee. Welcome you, Chavan, Niranjan Chavan, second time to Tiruchirappalli, and giving me the best of the opportunities. Over to Niranjan Chavan.
I think Dr. Niranjan is becoming famous second to COVID virus itself. He sent about 60, 70 slides of what he has done, and I was like taken aback.
So, he's a COVID warrior. COVID warrior.
So
thank you, Dr. Jayam, Nunnery Doctor, for this opportunity that you have bestowed on me. Mullakottai Pellayarukku Namaskaram.
That was Nandri.
Malakottai, sir.
Nandri.
So I am humbled by all of your introduction, Jayam Madam, and it's an honor to share today the platform with none other than the Iron Lady of India. I will not just restrict her to South India, because I can see many Iron Ladies sitting in front of me right now, but she is representing us. And today I feel that I have landed up in Chennai airport at about 10 o'clock. Then Jayam Madam's car was there. Joseph picked me up from the airport. From there, I sat in the back seat and we drove 320 kilometers. Before that, we had our lunch also at the famous Adda where you get the vegetarian dosa. And now I've just come in your conference, and we will be all joined by all of your Trichy Society members. And I'm sure many other members from all over India, Indian subcontinent are looking at you. An amazing feeling where virtually Shanta Madam and myself have come, and the warmthness and the happiness I can see on the faces of you all. Thank you, Dr. Vidya Ravi.
Thank you.
You are similar to us, like a professor, head of the department, and now having your own practice in Trichy. You're so nice, and it was, I can recognize you, we have met before. And yes, Dr. Deepa Mukundan, you're so energetic, enthusiastic, and full of life. And really, we all will have to see you co-moderating with me. And of course, I would like to go ahead and introduce Dr. Aruna Suman, who I have been knowing her since the days I know Shanta Madam. Thank you, Dr. Kavita Senthil, who gave us the lecture on low molecular weight heparin.
Thank you, sir.
It's a wonderful platform which I can see you. And from Mumbai, Hyderabad and Chennai, and we are going to go ahead with my presentation now, not wasting much of your time. So I would like to share the screen. Yes. Told to talk on do's and don'ts in OBGYN in COVID-19 era. And we are all learning. It's a new virus, and I hope you can see my screen.
Yes, sir.
Yeah. So this is, we are all aware that presently we are in COVID-19 era. We are in lockdown 5, and we have been told that we have to be safe, be personalized, and all our goals are towards achieving a mother and a baby. We find, especially during antenatal period, birth, and postnatal period. And there is not only SARS-CoV-2, but it's basically there are various other uh, different types of human coronavirus. We have also gone through the Middle East respiratory syndrome and the SARS-CoV, which we all know, but this is the most worst of all, causing pandemic after 100 years. We all know it has been developed in Hubei province in China, somewhere in their lab. In December 31st, it was there, blasted all over the world. And now we have got Europe, America, Italy, presently Brazil and Mumbai are the worst affected. India country, I hope the peak doesn't go more. I would like to share and thank my Dean, sir, Dr. Ramesh Barbal, sir, and my head of the department, Dr. Arun, to give me the permission to present you this data. It is just a small data. We are still in the process and we have put it and published to be in the journal to come. But 207 we have delivered. Ours is not a COVID hospital. It is a non-designated, non-COVID as well as COVID. And we cater to the largest slum area of Asia, that is Dharavi, and we are all in the red zone containment area. We had 207, out of which 101 were LSCS, normal deliveries were 70. We had the other antenatal patients who followed up, which came. And if you see, more of these sections were taking place. So 101 were LSCS. The total confinement was 207, but you have seen that 171 have delivered, and out of which the live births were 168. IUFDs were 7, 4 were twin delivery. So out of this 171 deliveries, we had 43 transferred and referred cases in-house. Those who are antenatally registered were 128, multigravidas were 107, semi-gravidas were 54, and 140 of them were term and preterm were 31. So this is the statistics, and we have more females than in males. Unfortunately, in my unit, we had only one death, but there were other deaths which were also occurred in other units. We have 6 units. We have total about 12,000 to 14,000 deliveries a year, and we have about 30 to 40, 35 deliveries a day. So my patient that was actually referred from one peripheral hospital, but she died on 31st day of LSCS done, which was done there, but she died in MICU with COVID-19 pneumonia and acute kidney infection. So most of you can see here, they were because of sudden desaturation. One had a head injury. On day 4, she had died. One was a septic abortion with COVID-19 pneumonia. Another one was day 2 of vaginal delivery, who landed up with pneumonia with DIC and multi-organ failure, followed by cardiac arrest. And the last one also was of severe anemia. She delivered on day 2 vaginal delivery with DIC help and COVID pneumonia. So this is what we see. The maternal mortality ratio is 2976 per 1 lakh live births. And in our hospital, the case fatality rate is 2.13. Perinatal mortality rate is 43 per 1,000. Now I'm sharing with you the report which came on 7th of May, where there was a video being circulated in the whole part of Mumbai, and then it went viral all over India. There were dead body bags which were lying along with the living patients, and there was a big UN cry amongst the whole masses and the Indian population, and unfortunately there was an inquiry, heads went rolled, but somehow we could withstand. What was our fault? We are just doctors, and it can happen because in pandemic situation you come across a situation where you have the staff who are doing all the time 24 hours, and I'm sure in Trichy also they are doing the same thing. And this was a bad situation. Then we had Times of India, and we had other senior reporters from the media who came down, took the interviews of residents and doctors, and that's how then the positive image. And I would appreciate Foxians and IMA and all the other aspects. They stood behind the resident doctors, the faculty members, and it was such a wonderful way of giving us the moral support. And that's how we got a positive news when we recorded about more than 100 babies, 100 mothers been delivered, and that really boosted the moral. I thank everyone to be with us. So this is what we face, the wrath of the people when you have such situations, and then we could at least survive, and that's how we have now made some name. And I am sure there are many hospitals who are doing a wonderful job all over the world. But most importantly, the transmission, as we know, is through the close contact through an infected person, and that's why we want to keep a distance of at least 6 feet or 1 meter to be precise. Or it could be because of the surface which you come in contact, anything with related to the mask or objects or hand, and subsequently then you touch your mouth, face and nose, and that's what happens. Right now there are 7 members of our department who are COVID positive. My own faculty member lecturer is positive since last Saturday, and her husband is also positive, but we are very happy that she's fine, she's home quarantine. Similarly, there are 6 other residents who turned out to be positive and they are recovering. So it's very important that this effects on pregnancy women should be known to us, and not only to them but to the healthcare workers, and they can have mild or moderate cold flu like symptoms, or 80% of them are absolutely asymptomatic, and it usually affects the black or Asian population as compared to the whites, but I'm sure in whites also it has affected in USA and in Europe. So basically, pathophysiologically, it's a hypercoagulable state. It leads to ARDS, it leads to pneumonia, it can further lead to multiple organ failure, and then we have a risk being associated. So it's very important that even if you're in isolation as a healthcare worker or a patient, you have to improve your mobility so that you do not come into the risk. And psychologically, you should be well and also counsel this patient. So we are all aware the incubation period is about 0 to 14 days, but there are patients who newly develop these symptoms when they get admitted because they are in vicinity of those patients or healthcare workers around, and that's where they land up asymptomatically, and later on they develop these symptoms. So it could be a newly onset respiratory symptoms suspected of COVID-19, or it could be an isolated case. There was also a general practitioner who posted on WhatsApp that in 50 cases he did Vidal test and it was found that the Vidal test was positive. So I took that task and I recommended that to my unit members that henceforth when we are having a suspected and a COVID confirmed patient, do send the Vidal. In few of these cases we found that it turned out to be negative, so it is totally not related to typhoid at all. So please remember that. Well, regarding the fetus or the neonate, it is currently no data being suggested that there is an increased risk of miscarriage or early pregnancy loss, and there is no evidence currently that the virus is teratogenic. However, it can be probably transmitted vertically to the fetus, but in our study of 106 cases, we did not have a single baby with having the positivity of COVID. So what are the advice for all the obstetric services which are caring for the pregnant woman? We all know, let's go through it. It's very important to maintain social distancing, protect your women, protect yourself, use appropriate PPE, and see that you treat the pregnant woman with comorbidities with more caution. So you have patients with hypertension, diabetes, thyroid, any other issues like immunological, autoimmune disorders. You have to see that you not only take care of them, but provide them masks and to their birth partners. And it's very important that rate of transmission doesn't occur between the staff. So we are always carrying that sanitizer with us and always having that mask, trying to avoid to touch, use a face shield, and try to maintain a proper distance of 2 meters or at least 6 feet between the colleagues, how much best ever practical it can be. And you have to adhere to the hand washing technique and the PPE guidelines so that you are very safe yourself and also to your colleagues and to the patients and their relatives. So antenatally and postnatally, we are aware that there is years of evidence to keep women and babies safe. And it's very important that now in COVID times, We do not want them to come so often to us. But I'm sure now in Unlock 1.0 or Lockdown 5.0, 5.0, we are going to have many patients which are going to come. So the best way is to do teleconferencing, video conferencing, and we always advise our patients to please come after 5 months, preferably. If you have not done an ultrasound, don't worry, we will get it done later, unless and until it is some congenital anomaly in the past, then you call them, give an appointment. And it's very important that you practice and guide this women to maintain social distancing with all the women, the staff, and the other paraclinical members, because they are very important to us. They are the backbone, they are the foundation, and it's very important. I remember Shanta Kumari madam saying that please do not induce labor, as far as possible avoid it, and it's what is recommended even in RCOG guidelines. And more importantly, see that when they come, you just take them accordingly, try to call them when only it is necessary and medically required. Obviously, where you require an ultrasound, do it now, but with proper precautions. As far as possible, we have known that radiologists or zonologists are also a source of infection, where we found that in the media there were radiological centers being sealed. So please use proper strict guidelines, and only when indicated, call these patients at your center, and then improve the provision of induction of labor accordingly, depending upon the availability of transport, doctors, and everything has to be done. Now, when it comes to the intrapartum services, I got about 13 members in my unit. I have given them a reference that they have to have a minimum staffing requirement. And from day one, that is 22nd of March, we have been doing that. And hence, luckily, all our residents of my unit and SMOs and qualified people are fine. We see that all of them work on emergency day with all the protection. So we have 8 a.m. the emergency starts. It goes till 4 p.m. Then 4 p.m. the new batch comes. Then 4 p.m. till 12 a.m. in the midnight. And then from 12 again to 8 a.m. So we are very sure that we have at least 4 people, that is one qualified, one third year, one second year, and one first year to manage at that time. And then the one backup team is not coming in the labor ward at all. So after this emergency is done on Monday, only one registrar, 2 housemaids are working in the labor ward, and post labor and post management in the ANC and the PNC ward. The rest of them are quarantined, they are safe, and they directly come on Saturday, which is my OPD day today. But we always maintain that social distancing. So I feel you have to have your own SOPs and see that you avoid coming to the department quite often, and you try to avoid mixing with other people. Just be focused and try to finish your work as early as possible. And also try to avoid the contact with the husband or the relative. And if they have any symptom, then you have to be very careful with them. Yes, there are symptoms which can come across like fever, acute persistent cough, hoarseness, nasal discharge, and we are all aware of this. So there is restrictions. We do not allow any birth partner to come inside the labor ward or any visitor. There is a mic system. We announce the name, and if any medications for anesthetist or we require, as we are government hospital, we have limited amount of drugs, but now in COVID era, we have got everything available. Oxytocin, prostodine, methergine, IV cath, everything is there. So luckily we are fine. But we minimize the number of residents, and we have made shift duties and duty roster during the emergency. And it's very important that these mothers have a good mental health, and they are always counseled. If we require, we take the help of the psychiatric department. There are counselors who treat anxiety, stress, depression, and panic attacks. So PPE, I have a video I will show you at the end of my presentation if we have time, as suggested by the 3G Society, and it has a disposable board, a gown, a coverall gown, and a 3-ply and an N95 mask, surgical gloves, disposable eye gear, shoe cover, and disposable bag. And it's very important that they are well certified. So I would like to tell you that there is one Institute of Nuclear Medicine and Allied Sciences. It comes under the Defense Research and Development organization under the Ministry of Defense in Delhi. They do this testing as per the circular of May 15 in Kanpur, and they are then further given to all the other government hospitals or private hospitals. So you can't just sell it off that way. You have to have a proper DRDO certification. This is how it looks like, the gown. It has to be put, mask, the goggles, the gloves, and you have to keep your hands away from the face, limit the surfaces to be touched, change the gloves when torn or heavily contaminated, do perform hand hygiene. And this is how you remove A, B, C. You remove one sleeve, the second sleeve, the whole overall. You wrap it, pack it properly, and put it in the container which is designated as per your hospital policy. Then remove your goggle, then the face shade, then last the mask. The mask has to be removed very carefully, and that is where you can land up with infection. So please be very careful. Every time, whenever you're doing this procedure, you have to do hand washing and use an alcohol base, preferably 70 to 60%, and that is to be done after removing all the PPE. I will show the video later on. If we have time, I have a video of donning and doffing. But it's very important that you have to do testing, and this testing is going crazy. The parameters change, the notification change, but clearly it's very important that you have to do testing of symptomatic patients, especially those who have traveled from international destinations, or those who have directly come in contact with confirmed laboratory cases. And obviously those symptomatic healthcare workers or frontline workers have to be tested. And if you are one of the direct or high risk contact of a confirmed case, do the testing at least once between 5 and 10 days so that you are very sure of what you're doing. Obviously, all patients who are bad and severe acute respiratory syndrome will have to undergo. And then there are those patients who come from the red containment zones or hotspots, and all hospitalized patients who are having the symptoms. Well, so we, in the initial aspect, when we started in March and in April, we had kits. So we used to do all the patients of emergency. We had 20 to 30 or 35 or 40 patients coming. Everyone we used to do, because we had to take care of ourselves, and we used to don the PPE. But since Monday now, we have been only told to do for symptomatic patients, not for all asymptomatic. If they only develop symptoms, then only you do the swab test. And it's very important that there are migrant laborers also, which we are doing. So it's all this thing you have to be understanding. If there are patients who are above 38 degrees Celsius, they have any of the symptoms, you have to do testing, and it is RT-PCR testing. In our hospital, we also did IgG, IgM. It was available from our microbiology department. I would like to thank Sujata Baveja. Most of them we tested negative. And now we have got a gene expression test, which is to be also done, and it is still in the nascent phase. So immediately, if you have a pregnant woman which comes to you who is suspected or confirmed, you require to escort with a distance of at least 6 feet to the isolation room, which is to be there in your hospital, in your area, which is designated. You should not have more of staff there, and see that you are properly wearing a PPE, and all these things have to be there. All non-essential items in the clinic and scan room should be removed before this woman arrives, and she should not touch anywhere. All clinical areas have to be also cleaned. So it's very important that you are having all this cleaned appropriately every time whenever you have a COVID patients coming, and then we assess them from the maternal point of view, the fetal point of view. If you require any multidisciplinary approach, do call a medical specialist. If you are having a consultant of respiratory IRCU, if she's having any breathlessness, tachypnea, any of these situations, you will have to take a help of a medical consultant. It's very important that apart from monitoring the mother, fetals, you have to have temperature and the thermal infrared temperature to be maintained, the respiratory rate, and we have the pulse oximeter which you put, and you try to assess it every hour or every 2 hours. And obviously we are going to do a cardiotopograph and NST and monitor this patient. So it's very important that When such situations come, we have a lecturer on call, an associate professor on call, and a professor on call. All phone calls come to me. Every patient has to be informed to me, irrespective whether she's low risk or high risk. And that's where the anesthetists are also standby, and we have a neonatologist which is there with us. We do not take any husbands or birth care members, birth partners in the room. And then when she goes in labor, following the decision of delivering her for whatever the reasons like PIH, anemia, or probably diabetes, or she's full term and she's near term, or there is oligohydramnios or IUGR, we then go ahead with an induction which is required with the proper consent, explaining the relatives, and the format has to be maintained same. If she has breathlessness, obviously we will have to monitor her oxygen saturation, and as per the standards, maintain and monitor the maternal and fetal aspects which I have already explained. More importantly, see to it that the oxygen saturation is always more than 94%, and that is how we had shortage. So we donated to my unit the pulse oximeter, one digital apparatus, one infrared thermometer, and we are very happy to say that Mumbai Obstetric Gynac, under the leadership of Dr. Jaideep Tang, when I was a secretary, we gave 200 PPEs, and now when Dr. Reshma Pai and Anaita Chauhan is there, they have given 100 PPEs more, and we have been also given 195, 50 face shields. So I'm sure your society is also doing the same thing, and all the societies are doing wonderfully job. Delayed cord clamping has to be done, and it is always recommended, but there are no other contraindications. That's what you have to see. The baby is to be clean and dried, and then we further go and give it to the neonatologist. Regarding the mode of delivery, it has to be an obstetric indication. Mind you, just because the patient is COVID positive, you do not take her for cesarean section. You should not be influenced by the presence of COVID-19 unless the woman is in a very bad situation, she has respiratory issues, and she requires urgent intervention for birth. So it's always safe if you decide to deliver her vaginally, well and good, but during the process of monitoring, if there is some issues, always remember to give her a spinal rather than a general anesthesia. You do not want the anesthesia team to be directly in contact with her mouth. So it's always better to give epidural or spinal anesthesia, and it has done a wonderful job in our patients. It's very important that what we are taking HCQs. So I'm sure Shanta madam will surely highlight. She's already done a lot of research on HCQ, courtesy Dr. C.N. Purandare sir, and we have all started HCQs not only to Mumbai police officers but also to the MCGM, healthcare workers, and even private practitioners being taking 400 milligram twice on the day one, and followed by 400 milligram once weekly for total 8 weeks. Presently, I am in the 7th week, and it's very important that any person or any doctor who is above 50 or 55, it is always better that you do not have a cardiac issue or any other comorbid condition. In that case, you will have to undergo an ECG because it causes certain amount of ECG issues. So we have to be very careful, like QT prolongation, or there could be some issues about ECG or tachycardia and supraventricular tachycardia. So we come to the ICMR guidelines, which are always there with us, and they have always said there might be difference of opinion. It has already been giving some. There are reports that it might give a false security, but obviously we are on HCQs. You people might be having a different thought on it, or you are taking some another drug. But I'm sure you all are aware that on 22nd of May, Lancet came out with such an article that it is not to be given HCQ, and remdesivir or any other antiviral would have been a better option than this. But then day before yesterday, Lancet retracted the statement, and this is also one of an Indian study which was there given immediately by ICMR that yes, this helps a prudent approach in Indian scenario. It has helped, and I am very thankful to the Prime Minister Modi that he has given to more than 25 to 30 countries all over the world where the export was removed, that notification, and it was exported to all the countries. And this is the latest study of June 6th which has come up, and I want to share with you. This is the COVID-19 vaccine, which is in development of pipeline. Yes, the Indian scientists are also doing in collaboration with Israel. We already know that there's an Oxford study, that is one study which is going on in USA, but we have already gone ahead and with 10 candidates in the clinical trial, it is still challenges, and Asher Muller is given this thing. This is done also by the University of Oxford and AstraZeneca, and this is what the paper says about. So I would like to end here with a take-home message, and I want to thank Dr. Aruna. Thank you. I just posted this on Facebook, but it was very important to be notified here, not only registrars or housemen, but please maintain social distancing. Hand hygiene has to be safe. You sanitize your hand again and again. Do not waste your time in chit-chatting, gossiping with your rooms, or go to another rooms and just do gossiping. It's very important that lecturers and other faculty members, please do not sit together during the lunch break. Stop sharing the food with your colleagues. This is COVID time, because you will take this home to your father-in-law, mother-in-law, father and mother, or husband who is above 50, 55, and that can risk to your members. And it's very important that you do not contract this. So it's very important that the next person doesn't get. Please stop celebrating birthdays in RMO quarters and cutting cakes and applying those cakes on your face and distributing, because that is not to be done. And do not meet anybody who is a stranger outside your room. I find some RMOs or some guys who are gang up together and they walk together in a batch of 5 and 8 or 10 without maintaining social distancing. You are doing a very wrong thing. I was also young. One day you will be old, but it's very important that you have to be all these things to be taken care of. People should not wander aimlessly. It's very important that it is, aimlessly people are wandering, just going to the department. Please take bath, take proper precautions, and take proper precautions during donning and doffing. It's very important that you have this message very clear, and do not, go ahead and do these things again and again. I think my slides are not moving. Can you hear me?
Yes.
Move. Just click. Go next.
Yeah. Okay. No, I don't know. It's something. It's not moving. But I would like to end here with my talk. There's nothing. We have gone through the whole thing. Now, I would like to thank all of you being here with us. And I would stop sharing this. We will get back to the questions later. If that is what, is it okay with you? And I have a data here where in India, in May 30, we had 1,73,000 cases. And now we are seeing that it is doubling. And today, June 6th, we have 2,26,000 cases in all over India. So you can imagine that in just few days time, 16 lakhs were there at the end of this month were added. And this is very important that somehow it's doubling, it's not getting controlled. So Meenal, if you can show the video of how to put, that's what was demanded, and I would love to share with you. Thank you, Dr. Shanta Madam. You were an inspiration. You said, Niranjan, you have to get it done. People have to see. And I really admire my residents who did the wonderful job. And this is a guide for PP donning. You can please put on the audio also. Dr. Dinesh has been kind enough to give his voice. Please start the audio also. This is Dr. Hera. She is opening the packet, and I would ask Meenal to put on the audio. You can just stop for some time and then again go ahead with the audio. Thank you so much. So this is how the PPE kit is there. You have to be very careful when you are opening. Dr. Hera is my third year resident and they are very good. My team of resident doctors, they have done an efforts, and if possible, the audio is there. Fine, no issues. I will give the commentary if it is having any issues, because we are in a technological era and there are going to be some amount of glitches and hitches. But I'm sure you will all enjoy this wonderful presentation.
Let them show the video.
Yeah, or you just show the video.
Video, and then you can talk.
Yes, that's what I'm requesting. Meenal, if you can please start the video, no issues. So this is the manufactured, as I said before, it tells you that all these things are available in the packet and we have to be very careful. So we open it, we unfold it. It has to be unfolded properly. Mind you, before you open this, you already sanitize your hand appropriately, and then we go ahead and unroll it. Okay. Now Dr. Hera has dismantled it very nicely. Can you put on the audio a little louder? The audio has to be done louder. The audio is only 50%. 50% is the audio. Can you increase the volume?
Sir, you need to, from the top, you need to select the computer audio. You're not selected. Kindly.
Sir, I'm not showing it. Sir, Meenal is showing. Meenal has to do that, sir. So this is the sequence which you have to remember, and it has to be displayed in your donning area. And you can see that the mask has been used. The cap has been already put there. She's in her attire. Dr. Hera is there.
First step is shoe cover.
Then we go on wearing the gloves. These are the nitrile gloves which are there. You have to remember that after these gloves have been put, you have to understand that the overall, the coverall has to be at least 60 GSM. Okay. And as per the notification and the order of the DRDO, it has to be certified. Then we have to go ahead and open on. This is what you put without touching anywhere as far as possible. You put it in the right leg. This is the foot cover. We can see that. Again, you have to put sterilium, wash it again.
Now next step is proceed to wear a coverall gown. Before you wear
Then we take this
just make it confirm the safety,
coverall.
the zip, and if there is any default.
Open the zip and loosen it up.
Start wearing the gown. All these procedures.
Put your right leg inside. Put the left leg inside.
With all safety precautions.
And then tuck it upwards. Both the arms, forearm has to be inserted inside. Or you put like a coat. And then once you're sure, you zip it up till the neck, totally covering it. So this is what is the PP. Again, you use the hand sanitizer. And you have to do it for 20 seconds. Don't be in a hurry. Then we use the 3-ply mask on the top of it, which is available in the PPE. See that it is totally covering your mouth, nose. Then we have this hood. It has to be opened up properly.
Hood to make more safety precautions.
See that it is put up properly. Yes. And then it covers up till the upper chest. You have 2 ribbons. You can tie it behind so that it doesn't move on either sides. And this is how Dr. Hera has been nicely doing it. Covers from the shoulder to full protection up till your chest. Then you have to wear the face shield.
And
This
then
is how it looks like.
the outer pair of gloves.
And the gloves have to be put properly. Now, it is very important that this is to be done properly. Okay. Now you have goggles also, which has to be put before the face shield. And now you are done with this proper donning. And I would like to thank Hitendra, Talini, and all the members, Dinesh, to go and do this video. Can we have the next video now of the doffing? So once you go inside, again you will have to scrub. When you go for a cesarean section or a delivery, you will have to again go up like this, scrub properly, where then you have the cloth gown, somebody then ties it behind, and then you put the gloves again on this, then you scrub with betadine, sterilium, ether, etc. The whole process which you are aware, put the drapes, perform the surgery. Once you are done the surgery, abdominal wall is closed, vaginal toilet is done, everything is done. Then you go to the doffing area. Keep your hands like this. So Meenal, can we have the doffing video now, please shown? Miss Meenal, please show the doffing videos. Thank you so much. So once you're done the surgery, this is our Dr. Shikanchi. She is from Raipur. She has done a surgery now. Now we will go ahead with how to go about removing. So this is the presentation: outer gloves, hood, overall gown, hand rub, goggles, mask, cap, then other aspects. So this is the way you have to go. You again use the hand sanitizer properly. Now donning is the most thing where people get infected, and this is what Shanta madam, I did this video at 12 noon, and it was really an effort done by my team. Thank you for that, pushing me ahead for this, and that's how we gently remove the gloves, one glove at one time, and then discard it in the yellow bag, waste disposal bag. Now you remove the hood, unzip.
And
Total the coverall is unzipped.
fill the vest in the rolling fashion.
Don't touch anywhere. Be very careful when you are taking this out.
Completely remove your PPE kit.
Do not touch anywhere, any other curtain or any other place. Once you have done, you can sit down and then remove from your foot area.
And put it into the
So we remove the foot cap along with the PP. We do not remove separately in Sion Hospital. Then we wrap it, discard it properly, roll it so that it doesn't touch anywhere, and then we again discard. Take the
remove the
sterilium on the hand and then again clean for 20 seconds. We wipe the procedure, remove the goggle, again discard it.
outer aspect of the mask.
Mind you, you're all drenched with sweat, so you have to be very careful, and this is the way you slide it up so that it doesn't touch any part. Once you have done that, then you remove both together, the cap with the left hand and then your right hand. If you're a right hander, then you remove your gloves.
That is correct.
You're all drenched in sweat. Remember, keep your hands straight. Right now also you'll have to sanitize again with hand wash. This ideally one person has to give you this, or you can use soap and then again clean this.
Like yourself.
And once 20 seconds you have already cleaned your hands, scrub it properly. You're done with it. Do not touch anywhere. Do not try to mingle it. Or don't have some. You might have to have some energy drink or probably a tea or a coffee with some biscuits, but try to avoid and maintain social distancing. So I think that is very important. I would thank Meenal for showing this from her side, and thank you so much for this presentation of mine. If any questions are there, I will take it at the end of the presentation of Dr. Kavita, if that is okay with all of you.
That was very good video. Good, Niranjan, you did it.
Thank you, madam.
So thank you so much, Dr. Niranjan. That was a fantastic, very practical and useful hints that you provided to all of us. Madam's suggestion of showing the donning and doffing video was absolutely very nice and very informative for us. I think how many times we read, we are not sure what to do when we get into a crisis. So it was fantastic. I think thank you, Dr. Niranjan, and thank you, Madam, for the valuable suggestion. Madam, you have anything more to add to this?
I think one more point shall I add, sir? Add, or I don't know if it is known already. Are these PPE kits ETO sterilized?
Yes, they are ETO sterilized. There are two types, and one is reusable. So we have orange, which are made up of rubber, where there are 500 of them have come, but they are very hot. It makes you suffocating because it's made up of rubber, and it can be reused, washed again by the linen department, and again given back to you. So that is the disadvantage and advantage of certain PPEs.
You also have certain PPE kits which are not ETO sterilized, but we do it in bulk in our GH. As a bulk, they sterilize it by ETO and then distribute. Is that also okay, is it?
Yes, it's fine. Whatever the government, whatever the availability of, I think initially in March and April, first 2 weeks, there were hardly any PPEs and we were all scared. But now I think it's made here in India and it's available here.
I think, Niranjan, what has happened is there are a lot of people who went into this reusable PPEs and all. We thought for our Indian scenarios, we need to look at cost-effective reusable PPEs. But right now, what are all those PPEs which they have shown are all disposable PPEs.
Yes,
it has been. So please have clarity in that right now. And then we are evolving. Maybe in future we'll come with. So as of now, I think we should be a little more liberal because we are not spending on other things. We are not buying saris. We are not buying jewelry. So please invest on the PPEs to save yourself. Even if somebody doesn't give, I think we should be a little more proactive to save ourselves and procure your PPEs and use it. This is my humble request to everyone. Don't wait. It is not there, so I'm not using should not be the criteria. Now slowly government setup has got a lot. So private and public sectors, both of them. And only one I wanted to add, I think even Aruna will tell. In the beginning, they were using the HIV sets.
Yes, madam. Yes, madam. In our GH also HIV sets were used before this PPE kits.
Shanta,
yes,
is there difference in the incidence of the medical people getting the infection when PPE was not used and now presently PPE is being extensively used?
Madam, I think Aruna Suman is the correct person to tell. You know what has happened? When PPEs in the beginning, nothing happened. Only when we started getting PPEs, and now only all of them are becoming positive. The people are becoming relaxed.
Our postgraduate students are not using the PPE properly. They don't know how to don it and doff it properly. And almost 11 members in our hospital, which is a government hospital, are infected. This is a very sorry state, sir. That's at present it is in Hyderabad.
I have a small suggestion. What has happened is Niranjan has very rightly told. See, when we put on the PPE, one thing is there are different about the size of the PPE and all. But now we have got big size PPEs also. And the other thing is the heat. When you put on the PPE, it's very hot. So you get irritated. N95 mask and a 3-ply mask together itself and the hood in the OPD itself causes distress. So what happens is as she has put for long hours of wearing PPE in the labor room and in the OT, these young kids get irritated and they're removing. I think that is what is one of the most important triggering factor.
Madam, I would like to add here, this is just the beginning. We are not only dealing with obstetrics now, but after 1 or 1.5 months, all of seniors will have to wear a PPE and operate on a fibroid, on an endometriosis, on TLH or whatever, endoscopy, God knows. So everyone is going to be high risk irrespective of your age, above 50.
Exactly.
So as Dr. Aruna Suman Madam said, the younger generation are little enthusiastic and energetic and bubbly. But then obviously our time is also going to come where we are supposed to be wearing this and really going ahead in the war, because this is going to stay for next 1.5 years. I'm sorry to say, Shanta, but I hope in the next 6 months we will get some idea. If the vaccination comes, it will surely. Now the community spread is already there, so herd immunity will come. But still, I think a lot of issues are there, and as you said rightly, do spend on PPEs and your personal protection and hand hygiene.
And most important is, I think there's one more thing. Some of the public sector hospitals, there are issues with the AC getting spoiled and AC not working. I think all the people should take adequate precautions and see that the air condition works. That will make this non-compliance with PPE much lesser. That's a very small thing, but I think that will increase the compliance with the PPE, because otherwise it's hot, stuffy, you feel like just tearing it out.
I know, madam, I know. So it was wonderful. Meenal, if you can show the last slide of my presentation, I want to share that quote. If it is possible, I want to share that wonderful quote which is there for all the Corona warrior fighters, for all the seniors who are guiding them. And I appreciate my all junior faculty members, the lecturers and assistant professors and associate professors, that we are always there, not only morally, but physically with you. And it is going to be a grueling task which we have to face together. We are all united and we are supported by not only the media, but not only by the government, but even by NGOs, even by the people who are coming. And I appreciate that once I put on Facebook, I got so many messages from people. They want to donate, they want to give a lot of PP. So I think that's very important. So success is not final, failure is not fatal. It is the courage to continue that counts. And each of you Foxians is courageous enough to continue this war against Corona. And I'm sure Trichy is also leading there in this front as a frontliner. And I'm sure we will all be there at the end of the presentation of webinar, and a lot of questions being answered by all the panelists and Shanta madam's effective way of dealing situations. We all will be very robust in our thoughts and in our knowledge process.
I managed to make you do the video in less than 24 hours. Thank you, Niranjan.
Yes, thank you, madam.
That was a great value addition, madam, for the juniors especially. Thank you so much, sir. I think we will go on to the next session. That is a talk on low molecular weight heparin by Dr. Kavita Sendil in recurrent pregnancy loss. I take pleasure in introducing our own member, Dr. Kavita Sendil. She's a fertility specialist and cosmetic gynecologist. She's trained in laparoscopy and infertility from Germany. She has presented many papers in national and international conferences. She's won the Best Paper Award in AICC RCO 2011, Dakshin South Pole, and Yuva Foxy 2013 as well. And she was a South Zone Yuva Foxy orator for 2013, and she was the past secretary of Trichy OG Society. So welcome, Dr. Kavita Sendil, to go on with your presentation on low molecular weight heparin.
You're not audible, Kavita. You can start, Kavita.
The slides will be shared by by Meenal, ma'am. My slides will. Should I share my slides, or Meenal will be doing it?
You can share your slides.
A warm good evening to one and all there, and my respects to the seniors in the Foxy. You're able to hear me, ma'am?
Yeah.
Yes, yes.
Yeah.
My respects to the seniors in the Foxy, Dr. Shantakumari ma'am, Dr. Jaim Kannan ma'am, and Niranjan Chavan sir. And my heartfelt thanks to the President and Secretary of Trichy ONG Society, Dr. Vidya and Dr. Deepa, for giving me this opportunity. And my wishes to Dr. Aruna ma'am and Arulmozhi ma'am. And my topic is really an odd topic in between a very important topic going on here. And this, I'll make it short and sweet for just 10 minutes. That's what Dr. Chavan has told me. My slides are not moving.
Go down, there will be a next.
Yes, ma'am. Thank you, ma'am. Yeah. Topic for today is role of low molecular weight heparin and recurrent pregnancy losses. Starting from definition, the definition goes by this, like 3 or more consecutive losses of clinically recognized pregnancy less than 20 weeks of gestation. And we don't take into consideration about ectopic molar pregnancy or biochemical pregnancies. And clinical investigation, we usually start after 2 or more consecutive spontaneous abortions. Going to the incidence, about 50% of all conceptions fail, but most of them go unrecognized. Only 13 to 50% of all recognized pregnancies are documented. About 90% of them are before 12 to 14 weeks. And 10 to 20% of pregnant women who have 1 sporadic spontaneous abortion at least. 2% have 2 consecutive spontaneous abortion, and about 0.4 to 1% have 3 consecutive abortions. There are basically two types of RPL, which is primary and secondary. Primary RPL refers to a couple who have not had a live birth. And secondary RPL refers to those who had a repetitive losses following a successful pregnancy. And we calculate the risk of pregnancy losses by the woman who have had at least 1 live birth with no previous losses has a risk about 12%. And those who have 1 previous loss have 24%. And it goes like that. If it is 3 previous loss with 1 live birth, it is 32%. The women who have had no live birth with 2 or more previous losses have a high risk of about 40 to 45%. Coming to etiology, about 50% of the RPL, we don't know the etiology. And only for the remaining 50%, we have etiologies from uterine, structural anomalies, immunological anomalies, etiologies, endocrine etiologies, genetic etiology, thrombophilic etiology, and environmental etiology. Just to evaluate the RPL patient, we have the history taking plays a very important role. Gestational age of the previous losses counts very important, and irregular menstrual cycle has to be noted. With history of galacturia has to be taken into account so that it guides us to a possible method, like if it is a endocrine dysfunction or any other dysfunction. History of consanguinity, family history of congenital abnormality, a family history of continuous fetal pregnancy losses has to be recorded. And environmental factors like alcohol or caffeine intake has to be taken, like drug abuse, alcohol, caffeine, all this has to be noted. PCOS history also plays an important role. This is a slide which I made it very simple, like what all investigation we usually do for the RPL. When it is a uterine factor, a simple 3D ultrasound or a sonohysterography, hysteroscopy, or even an MRI can tell us a structural abnormality. Antiphospholipid syndrome is the most common cause of RPL, for which we have to do an anti-cardiolipin antibodies and anti-beta-2 glycoprotein 1 antibodies and lupus anticoagulants. And in endocrine abnormalities, it is thyroid stimulating hormone, thyroid function test, full thyroid function test, and prolactin. And we have to do a fasting glucose and HbA1c. If we think it is in a genetic mode, we have to check for karyotyping of the products of conception and parental karyotyping. And as I already said, for environmental factors, we have to screen for smoking, drug abuse, etc. And we have to think about in a psychological aspect also. And for male factor, DNA fragmentation of the sperm has to be done. And as we all know about, and our topic is about low molecular weight, I'm confining myself only to thrombophilia. Thrombophilia and RPL. RPL and thrombophilia is very important because about 40 to 50% of RPL cases come under this. As we all already know, the pregnancy is in hypercoagulable state. it can worsen the thrombophilia by impairing the blood flow, leading to a multiple small microclots in the placental bloods, which it can lead to IUGR, sudden fetal demise, and preeclampsia. So screening for thrombophilia, usually we do factor V laden, PCR for thromboplastin, prothrombin gene mutation, protein S deficiency, protein C deficiency, antithrombin deficiency, antiphospholipid antibodies, anticardiolipin antibodies, anti-beta-2 glycoprotein antibodies, glycoprotein 1 antibodies, and lupus anticoagulant, hyperhomocystinemia. According to ESHRE 2017, the screening guidelines are women with RPL screening is not recommended for hereditary thrombophilia unless in the context of research. Otherwise, it is not going to give any additional information. Screening can be in the same guidelines. The screening for RPL is recommended only in antiphospholipid antibodies like lupus anticoagulant, ACA, and ACA for IgG and IgM. Following if there is 2 pregnancy losses, and also alpha beta 2 glycoprotein 1 can also should be done along with this. This is only the guidelines we usually do for the APLA syndrome. So as we all know, anticardiolipin antibodies IgG and IgM at a moderate or high levels, it has to be recorded in 2 occasions at least with a 6 weeks difference. And similarly, lupus anticoagulant antibodies also detected for 2 or more occasions with 6 weeks difference. Now coming to the management, as all of us know, anticoagulant is the management. So this slide I have made it very simple for understanding. As we all know, heparin is the drug of choice. Heparin along with antithrombin 3 will form a complex. This complex will go act on factor 10A, inhibiting the coagulation cascade. So it can also have minimal actions in prothrombin, factor 11A, and factor 8. We just have to remember only one thing. It is so complicated. Heparin antithrombin 3 complex will go inhibit the factor 10A. To this will form the anticoagulant action of the heparin. As we all know, heparin is a drug of choice because it doesn't cross the placenta and it has no untoward effect in fetus or newborn. And we have heparin as unfractionated heparin, low molecular weight heparin, and fondaparinol. Heparin itself is inactive as an anticoagulant. It requires this antithrombin 3 factor to form the complex, and then these complex neutralizes the factors of factor 2, 10, 10, 9, 10, 11, 12, and 13. This is how it acts. The adverse effects, heparin has an adverse effect of inducing thrombocytopenia and thrombosis. When it is given in large doses and for a longer duration, it can cause thrombosis and thrombopenia and thrombosis, which can also cause sometimes MI or stroke. Now, other side effects of heparin will be major bleeding or major bleeding only for 5%, and osteoporosis is for a minimal percentage, and anaphylaxis, skin necrosis, local atric area are few cases reported. The very important point and difficult point in administering heparin is monitoring it. Therapy is routinely monitored by means of an activated partial thromboplastin time. Initially, APTT should be measured according to the infusion rates, and it should be adjusted every 4 hours. And once we achieve a steady state only, it can be monitored daily. Otherwise, it is very difficult to monitor every 4 hours. There is also certain conditions where this APTT will give you a false positive. Like if it is like in an inherited antithrombin 3 deficiency, it will be difficult to monitor with APTT. And similarly, in conditions like hepatic necrosis or nephrotic syndrome, or in a case of DIC, there will be an acquired antithrombin 3 deficiency. This will also cause some confusion. But the very important advantage is anticoagulant effect of heparin will disappear within hours after discontinuation of the drug. There will be only mild bleeding which will usually be controlled, even without an administration of antagonist. And we have already antagonist available also for it as protamine sulfate. All of us will be knowing about it. And the dose will be 25 to 50 microgram intravenously, it should be given. And as we all of us know, the drug of choice today is low molecular weight heparin, because all the side effects which is caused by heparin will not be there in low molecular weight heparins. So it contains a lower portion of critical pentasaccharide sequence than the parental heparin compound. They increase the action of antithrombin 3 factor, but it doesn't have any action on thrombin. The low molecular weight heparin are not inactivated by platelet factor 4. Therefore, it doesn't have any this factor doesn't have any action on platelet. So there will not be any, in clinical doses, no effect will be seen on platelet reactivity or PT or APTT. So we don't have to monitor. So it does not require any routine monitoring in INR, PT or APTT. And the dosing is also very simple. It can be given 12 hours apart, either OD dose or BD dose. It has been administered as subcutaneously, and so patient can take by herself. It is available in a convenient dosage also. Patient, and it can be used, it should be used only with patients with heparin-induced thrombocytopenia. And similar, same protamine sulfate is the reversal agent for low molecular weight heparin. The dosage is similar, 1 milligram per kg of low molecular weight heparin. When we compare all the three, unfractionated heparin, low molecular weight heparin, and pontoparino, low molecular weight heparin is found to be beneficial, and it is found to be the drug of choice. As because it has a reversal agent, it doesn't need a routine monitoring. Dosing is very easy. Clearance is there. It is safe in pregnancy and breastfeeding. What is the evidence says? And from ESHRE 2017 guidelines, the use of anticoagulant in RPL for women who fulfill the laboratory criteria and the history of 3 or more pregnancy losses, we suggest administration with low dose aspirin 75 to 100 milligram per day starting before the conception, and along with the prophylactic use of unfractionated or low molecular weight heparin at the date of positive pregnancy test. And even RCOG suggests the same. Pregnant women with antiphospholipid syndrome should be considered treatment with low molecular low dose aspirin plus heparin to prevent further miscarriage. This is what is given in Green Top Guideline 2011. And Cochrane Library, they also say enoxaparin prophylaxis increases the live birth rate when compared to low dose aspirin alone. And there are, and also from ASRM, it is the same. The standard treatment documented for antiphospholipid syndrome consists of low dose aspirin and heparin, which is superior when compared to the treatment with aspirin alone. So the combination of, they consider unfractionated heparin to be a better combination with low dose aspirin when compared to low molecular weight heparin. Otherwise, heparin is the drug of choice for recurrent pregnancy loss. There are few other studies also supporting the low molecular weight heparin along with aspirin, low dose aspirin. So the take home message is low molecular weight heparin is found to be more beneficial when compared to other heparin in a case of RPL, because it is easy to administer, no monitoring required, patient will be taking it by themselves. Thank you, ma'am.
So, thank you, Kavita, for the nice and short and sweet presentation on low molecular weight heparin. Actually, and vaccines, who are the major sponsors for today's wonderful webinar, is dealing with low molecular weight heparin, and as a mark of honor, we wanted to have this topic today. I think it's time for, we'll reserve, I'm sure you'll get questions from the audience as well. I think it's time we move on to question and answer session. Anything the panelists or anybody wants to add to Dr. Kavita, or can we reserve that to the question and answer session?
Shall we go to the question answers? I think that's better, Deepa.
Yes, ma'am. So Dr. Niranjan, back again with us.
Yeah. Madam, please continue. Go ahead.
Okay.
I'd just like to introduce the panelists. Dr. Aruna Suman, she's an associate professor, MGMH Osmania Medical College. She's the vice president, OBGYN Society, Hyderabad, signal review member in Indian Pharmacopoeia. And her subject of interest is high-risk obstetrics and infertility. Welcome to the panel, ma'am. Thanks for being here with us today. The next panelist who is going to be with us is one of our own members, Dr. Arun Mori. She's a senior gynecologist. She's done her postgraduate diploma from Raja Muttiah Medical College, Annamalai University in 2001, and she's been a gold medalist for the outgoing year 2003. She's a very active member of TOG since 2004. She's also one of our executive committee members. Welcome, Dr. Arun Mori. I think good to go with panel and the sir. Dr. Niranjan?
Yes, madam, I am there. You continue with the presentation. There are the questions which have been asked.
So we will continue with the question answer session.
Yeah.
Please.
The presentation is, yes.
Yeah.
Inal has already sent the questions. Already there. I have already sent to you, madam.
Okay, can you?
I have a question for Dr. Kavita from Dr. Sudha Agarwal. How long should heparin be continued in case of recurrent pregnancy loss? If an antenatal patient came in
until onset of labor, the heparin can be low molecular weight heparin can be continued until the onset of labor, or if the patient is not in labor, or if patient can be continued till the date of delivery.
Okay. Deepa, the next question is, if an ANC patient comes in the 3rd trimester for checkup, we advise COVID-19 test for future deliveries. What is this? Necessary to inform CMO for sample collection and time. I think this is a very controversial issue. So because even you remember Niranjan has already told, and all of us know, that right now the testing criteria are changing. Can I have Aruna Suman to answer this about any patient coming in 3rd trimester about checkup and about COVID testing?
Right now in Hyderabad at Modern Government Maternity Hospital, which comes under Osmania Medical College, we have almost 40 to 90 deliveries per day. Because this is a tertiary care center and this is a referral center, we have cases from all over Telangana. So right now we are not able to do the test for all the women who come in last trimester or who come in labor. But right now we are planning to do for all the elective cesarean sections if there is time.
So I think
in a suspicious patients, whenever she is coming with symptoms, we are sending, we have an isolation room and we are sending for tests. We are doing the tests.
Niranjan, you also told nowadays you're not doing for asymptomatic, right, in Mumbai?
Yes, madam. You're right. We don't do nowadays for asymptomatic because now as per the ICMR guidelines which has come on 18th of May, we are following those guidelines only, madam.
Okay.
There are viewers I would like to share that they are from Mombasa, Philippines, and also from Southeast Asia. I think it is the charisma of Dr. Shanta Kumari. Shanta Kumari has already. No, I was just going through the questions and having some tea. Okay. So obviously we have questions from Balanga, Kolkata, Nagpur, Hubli, Mangalore, Ramanapuram, Salem, Usad, Allahabad, and there are many of.
Trichy has gone global.
Known to us. Yes,
because of the 2 doyens.
Thank you. I think because we are having you all on the screen.
Yeah. 2 doyens.
Okay, so there's one more very interesting question. What general advice? No, is it the gynec's responsibility to advocate contraception for patients in this COVID season? What do you think? This is Dr. Vidya Shankari has posed a very interesting public. I think it's a public health issue question. So before I ask the panelists, can I ask your president? Yes, Dr. Vidya Ravi?
Yes, madam. Tell me, madam. Actually, during the COVID lockdown period, we used to get more of MTP cases. So
Yes.
seeing that I mean, we understood there was no social distancing at all. So it's a must that a gynecologist, when they see any patient, when they look for any, I mean, any disease, if they come for with any symptom, they are supposed to advise family planning measures accordingly, according to what the patient is comfortable with, or a permanent method of sterilization if she is COVID negative. So this is what we follow in government hospitals, madam. We always counsel them for any family planning methods. Usually,
what I need to share is now what the FIGO has also done a study, the IPAS has done a study, and what they have found was, they're absolutely right. The women who are actually access to the contraception, family planning services has been affected more than 60-70% in this lockdown period. I'm sure
has been affected with COVID.
No, in the lockdown,
access to
the services.
Yeah.
What has happened is, we had actually put on hold elective OPDs and all those. So when there was a study which was done, they found that this access was denied, and that is where even the FIGO, everyone is trying to see how best we can offer these services to the women, how the telemedicine, all these aspects can be used for the better health.
Yes,
so I think as we are evolving, we have to remember that though we may think that a delivery and a cesarean section is an emergency, but even the contraception, sexual and reproductive right of every woman, and access to these are very vital, and access to the medical termination of pregnancy, that this is also a woman's sexual and reproductive right. So these are the factors which we have to actually see and see how best our women can receive them.
Yeah, I think this would reduce all the risk of MTPs, family planning methods advised by any gynecologist for the patient will reduce definitely the risks of MTP.
Okay, now there's one more interesting question I'll ask Dr. Arulmoli regarding the maternal mental well-being. Non-COVID negative pregnancy in labor, whether PPE is a must. There are two questions. One is maternal mental well-being, and the other one is non-COVID negative pregnancy. How do you know when you're not doing tests? So whether PPE is a must. Dr. Kamla has asked. Yes, Dr. Arulmoli, where are you?
You have to unmute your audio, Arulmoli.
Sorry.
Yeah.
We have to consider every patient or any patient who walks in as a COVID positive for their safety and also for our safety, even when they are not proved positive or even if they don't have any symptoms. So I think it's better to don a PPE while conducting delivery. Okay, madam. Pardon?
Niranjan, what would you say?
Madam, I was just eating a biscuit.
I know. We are not seeing you.
Sir, you promised to get us all a dokla, sir.
And really the taste is so good that I want to show this curry from Bombay.
Thank you.
Thank you so much, sir.
Thank you.
Sir, you said you will get us a dokla from Mumbai. Sir, are you here?
No, madam. There are many questions, but what is important is now today it is Trici's day. Okay. We are visiting as honorary, senior people. So there is one, in Trichy local language, Makkal Kelly Kalangu. I hope I.
What is it? Makkal?
What is it? Makkal Kelly Kalangu.
Makkal Kelvi Kelunga. Ask questions.
I just
dear
wanted
people.
to
ask questions.
Yes.
See, there are many false negatives, right? So that question was very relevant. Someone asked whether if the patient tests negative, so do we don a PPE or not? We are not sure whether the test is false negative, or many times at the time of admission the patient tests negative.
Negative. They can turn positive.
that they
Dr.
become
Deepa, we have not been doing the test for all the patients. But we treat everyone as a COVID. The woman in our hospital tested positive after doing a cesarean section or after delivery. That's a dangerous situation where we'll have to get ready and be ready to face the situation.
I think it's universally acceptable to use PPEs for all patients, testing or not testing. Yes, ma'am. Thank you. And Dr. Niranjan is not there. I'd like to know the role of heparin in COVID positive patients. Have you used, Madam Dr. Aruna Suman? Because we know that
I don't have any experience regarding this heparin during COVID era in COVID patients. I don't have any experience.
Actually, I think, Deepa, this question is directed to medical people who are medicine specialists who are treating the COVID patients. Yes. See, we are only treating the obstetric part of the COVID.
Yes.
Obstetric. So what is happening is when the patient becomes COVID positive and all, the physicians come into the role. They are and the intensivists. They are the people who are actually dealing with these cases, and how they deal and what is the medicines they are using should be answered by them. We are like how to prevent infection, how to keep ourselves safe, and how to keep our patients safe, so that they are also when they come to us, we deliver them and treat them properly. That is our domain. So
and ours is a non-COVID hospital actually.
Oh, Aruna, can I have a question with you?
Yes, ma'am.
You are a non-COVID hospital, but you have delivered a patient and you found her to be COVID positive.
Yes.
So after a cesarean, you quickly transfer home or keep her in the hospital?
No, ma'am. Actually, she developed the symptoms of respiratory failure.
Asymptomatic.
Asymptomatic patient was never tested positive because we don't test them. But when she had symptoms, yes, we tested, and she went into respiratory failure. She was shifted to ventilator, and actually we shifted to Usmania Hospital where they take care of the patient. From there, they'll send the patient to Gandhi Hospital, which is a COVID hospital.
So you don't send them asymptomatic back home?
Oh, madam, they don't even test the asymptomatic, madam.
If she is COVID positive, definitely we refer her to a medical department where they take care of the patient.
That is the horror in Chennai. Everybody has to be tested, and unfortunately the cases 2 out of 3 are turning positives, and we are in a soup to do what it is at Chennai.
Because 80% are asymptomatic carriers.
Everybody before delivery and after, and on the day of delivery, on 5th day of delivery, are being tested in Chennai.
Madam, Chennai is a hot spot, madam, so you have to test.
That's what I'm saying. You take 3 tests and 2 are coming as positive. All
Yes,
are asymptomatic, and they have been tested 4 days ago negative.
But I think asymptomatic can be kept in any hospital, madam, even though they are positive. Symptomatic has to be referred to a particular center where, they take care by them.
I wanted to give some reply.
There are actually 2 sides of this issue. One thing is testing. Once you do more testing, obviously more number of cases will come positive. So when your testing is less, obviously your case number will be less, because all the positive will not have symptoms. You have to understand that. So whether you have to look whether you're going to do a generalized testing for, in Telangana we have 50,000 per month, both public and private. So 50,000 deliveries, if we are ready to do, the issues are there. So many things, the government, non-government, the private parties, whether being allowed to do the testing or not. But in this scenario, we have to look at it as a public health perspective. So that is the reason why the testing has become a little controversial, because people, you have to look, you can't look at it with a tubular vision.
Shanta, please look at my position as an obstetrician who has delivered the case. Please look at me. We for ourselves first.
No, that is what, madam. That's
for obstetricians, what to do? Now my house is saying,
madam, standard precautions and standard care. That's what we'll have to use. Like universal precautions be used for all HIV patients. Now we have to follow all standard precautions. Treating everyone like COVID positive. That's it. I think so.
And Jaya madam, you shouldn't be doing cases. I think you should let your juniors do the cases.
Yesterday it so happened that the other doctor was not there. So I went and assisted my daughter-in-law.
Oh.
Right? Because there was another delivery in the next at the Cloud9 hospital where we were doing the deliveries, one vaginal delivery and 2 cesareans going on. So the register was not available, meconium stain like.
We may have, Madam is so famous that people may insist that she must come for delivery. We have another question. I think Dr. Niranjan can take this. Are patients with COVID positive patients still infectious after 30 days? We have cases whose symptoms have resolved but still running positive on day 30. This question is by Dr. Julius Maina.
Yeah, because we don't have any studies which tells us that for how many days they are positive. Initially, it was the incubation period from 1 to 14 days. Now, after being home quarantined for symptomatic or asymptomatic or getting treatment, then they say that you repeat the test after 14th day. Now, last week, by this Monday only, this Monday, the MCGM said that no point doing a testing on 14th day to find out whether it is a negative or positive. But if the patient has recovered, do it on 19th day. So 19th day is that's what we do in Mumbai now. But the studies are still not very conclusive, and they find that the virus is excreted through feces even after 28 days. So we don't know. But most importantly, from healthcare workers' point of view, whether it is present in the body or whether it is outside the body for next 1 month, we have to remember that we have to wear this for next 1.5 years. So that is very important message rather than just going through the statistics. And as rightly said, Jayam Kanan madam, that we should do for all the cases, but unfortunately, the guidelines of ICMR say that we are only supposed to do for symptomatic. So thinking that any other patient which comes to us, you have to think that it is a positive patient and then do the management accordingly in all aspects. In OPD, actually in OPD, we do not require to wear a PPE, but still people wear a PPE because you don't know whether it is a COVID positive or a suspected case. So, but there are many general practitioners and many gynecologists in the private nursing homes. They are daily wearing, because in the morning they are sitting for 4 hours or 6 hours, not more than 6. So they wear PPE. Again, they go in the afternoon, have lunch, and they come back in the evening for 4-5 hours. So naturally, it is always better that, though the ICMR guidelines doesn't say, but for our protection, thinking that this patient is positive, always better that you wear a PPE. It is not ideally recommended. They only recommended a gloves and an N95.
No, Niranjan, I think that 30 days positivity, it could be that, see, the patient has delivered or whatever and gone back. She could have contracted the disease in the postnatal period or post.
Yes,
so
yes.
It's a very difficult. You can't think that 1 month later she had.
And now, madam, like apart from as a healthcare worker, we are also going as males or even females also, lady doctors. They are going and getting bhaji and sabji and from any mall or any mart or wherever.
Yes.
So in a day, you meet the watchman to the driver to the vendor or to any other thing. So how can you now pinpoint to trace the contact, because it is now community spread. So it is very difficult to identify and make a list. Though the MCGM has got a very big form to be filled, but still there are many things. And there are many questions which have been asked. And obviously, the revised ICMR testing strategy, Dr. Ramesh, we have already discussed on May 15. It has come. Yes, Dr. Deepa.
Can I make a note, sir? I just came across some articles on this testing. What we are testing is RT-PCR. Actually, it detects the viral particles. We are not sure whether they are live or dead. So this question we had about testing positive after 30 days. It's possible that the virus is still there in the body, but the infectivity is what matters. Whether that patient is really infective, I think there are many reports saying after 11 days or something, the patient ceases to be infective. they are not infective. It's just that the test is positive.
There is one question. Hi everyone, I think every part of PPE kit is touching bed floor and everything seems it will be unsterile. So show us how it can be worn in a way where sterility is maintained. Dr. Yoga Lakshmi SK. Now madam, for that I will have to stand up on the stool and wear it. You have to understand that this PPE is only to protect you from splashing of body fluids or amniotic fluid or blood, or you have a direct contact with a COVID patient, so that you wear that mask and 3-ply and N95 and that hood. Whether it becomes sterile or unsterile is not important, because after you wear a PPE, you have to scrub your hands again for the way you do a procedure if you are doing a surgery, and then you have to wear gloves on whatever you wore, and then there will be a gown which will be tied back by the assistant. So please do not get carried away. You have to understand that this is only, and people in spite of wearing, contracted COVID. So please remember that.
And PPE are not sterile. We have to wear another gown on that.
And another question to Dr. Niranjan sir, how do we sanitize cardiotocography after use? Dr. Reena Shrestha.
This is Dr. Reena Shrestha from Nepal. So Trichy Society has gone to Nepal also now, apart from Philippines and Mombasa. Because I remember Dr. Reena, she is a very great fan of all the webinars, especially when Dr. Shanta Kumari comes and I come.
Niranjan wants to be very this thing. He has become the, what to say, hero of
webinar.
Now for that matter, it is coming back to the question of Dr. Reena Shrestha. You have to understand that you cannot start cleaning the OT table, the electrocardiogram, graphy machine, the ECG machine, the ultrasound machine. It is cleaned only once a day. I hope. Otherwise, your staff will run away by cleaning everything. The idea is that whenever you are having such a patient which comes in the labor ward, because even your electrocardiogram, there is no F-form or anything, ultrasound machine, etc., where you have to follow. Nowadays, we have got portable echocardiography. So, if you are dealing with any patient in the labor ward, think that that patient is a COVID patient. Whether it is positive, negative, because even if you do a testing, the result will come after 3 days. So you will have to maintain utmost precaution and see that you have to use sterilium or a gauze piece and sterile and clean it that way. So that is the basic, and see that your gloves, so that you do not come in contact with any COVID. That is the whole idea.
And cleaning procedures for operation theatre by Dr. Hemalata. Anyone?
We have to have the use, madam. In our OT, we have got 10 to 12 cesarean sections. Every OT table, after every case, we have to, clean the OT surface properly, whatever we do the procedure. And the next case has to be kept ready. We use this sodium hypochlorite, which is the disinfectant used for COVID, or you can use sterilium or an alcohol-based preservative to clean the OT table, so that when you are going, it's not only that, even the anesthetic equipment, even your surgical equipment which are autoclaved have to be tackled. So each and every case, whatever you are doing with all the aseptic precautions, you will have to clean them properly before each case. Please take a consent, madam, please take a consent that if you get admitted in our hospital and if you contract COVID, we will not be responsible for that. So you please take a consent also, madam. Very important.
Good point, sir.
Because it is very important, that point, because people now call me for various other things. I got a brain tumor, I want to get operated it in this Sion Hospital neurology department. I got some renal kidney dialysis, because most of the time we are now working, and for doing COVID work only, Aruna madam can agree with me, because she is in a tertiary center. So there are other police officers, some distinguished members of the parliament, and even the assembly they call, because we are directly as a public servant, we come in contact with them also when we are working in a public hospital. So, but naturally, we have to be very polite to them. I cannot afford to send any doctor to escort them or take them. What is important is that we are all doing COVID work now. That is very important. And elective work can be little postponed. Suddenly, I have not seen a fibroid. I have not seen an ovarian tumor. I have not seen that ovarian tumor in adolescent girls. I have not seen PID infections.
Be happy, sir. Be happy.
They are scared of you.
And I have seen patients have conceived on their own.
Yes, yes.
You should be happy at this situation, sir. So thank COVID.
Stress-free environment.
And there's a question from Dr. Priya Vasanti. She's our member. When to wear PPE in a patient with labor, even in private practice, even when doing
Yes,
PV exam?
So whenever you're doing, you don't have to wear for PV examination a PPE, but you're talking, there are two different things. One is in labor. So if you have got a turnover of say 5 or 4 deliveries a week, if you're in a private practice of say 20 to 30, 35 deliveries a week in your small nursing home, which is 15 bedded, 20 bedded, and I'm sure you will all agree, whenever such a patient comes, we have to take protection. Electively, if you are calling induction of labor, you are doing, there is no protocol as per ICMR guidelines to take a swab in the beginning 3 days before, and then you confirm, and then she will come with a COVID report to you. It is not been advised now. So each and every patient you will have to treat as a COVID positive, and if she comes in a labor, you should welcome her with that, not that South Indian sari and gold jewelry, but PP is your gold jewelry and your gold threaded sari.
Agreed. Uniform.
Yes. So maybe South Indian, or maybe they can come with PP which is made.
Saudi Arabians, they wear a head hood.
So you have to be very careful, madam, and I wish you all the best. Everything will be fine. We will have to take care of that.
There is a congratulatory message, Dr. Niranjan and Dr. Shanta, from Dr. Asma. We have been seeing all TOG webinars and following Dr. Shanta and Dr. Niranjan's programs. Excellent conduct and fantastic connect to the audience, Dr. Asma. I think there we get the answer why Trichy is gone to the global scene. So truly because of two celebrities, madam. Thank you, sir.
No.
And
celebrities.
Niranjan and I have been traveling. We started our travel. First was from Mumbai to Pune, which both of us will never forget. We'll have to do a webinar on that.
But the exciting or the inciting or the provoking factor was not me. There was another person. There was another guy who irritated both of us. And we both got irritated on him.
I know.
That lasted on both of us. Ultimately, I still can't remember certain things, but I'm very sure that women are even 20 years, what happened, what sari was worn, and what jewelry, what it was, and what conversation women, it's an inherent error of, I will not say error of metabolism, but I remember that they have got a very powerful memory. Congenital, yeah.
I'm sure Niranjan, my husband, also will agree with you on this aspect.
Yes. Everyone will agree.
All males.
all males will agree. And I remember this because Dr. C.N. Purandare tells me this. He tells me when we go out or when we have this discussion, he has told me twice this thing, that they will remember everything. They will remember all details. So thank you, Shanta. And it was wonderful.
Thank you, Niranjan. We enjoyed. Bye.
We
Any
have
more questions?
Audience which have been there. I think we have crossed, I'm not sure, but approximating 1,000 members on a weekend have come to Trichy, and they had Medu Pongal, Idli, Dosa, Medoda, and all the, we had sumptuous snacks.
But you wouldn't give us anything from Mumbai, sir. Sir, you didn't give us anything from Mumbai.
Next time.
You never. And
gave us, right?
Oh,
He gave us.
Yes.
And also from Hyderabad, we didn't get anything.
To biryani, I'm sending
Biryani.
Yes, sending you.
Hyderabad, biryani.
Thank you, Manu. Thank you. The words you say itself, we are really pleased. Like, it's really nice having both of you all. It's really a fun time more than a scientific time.
Yes.
We had combined both the scientific as well as the webinar was, as the participant has said, it had a real connect with everyone. So it was really
one last question Niranjan will answer and we are going to leave.
Okay, madam.
Dr.
Madam,
Anantalakshmi had a doubt.
Madam, I would like to add here that we have got nearing more up to 1,000 members who users have logged in.
Very good.
And they have enjoyed everything. There is one more question as what is the preferred analgesia to be used in COVID-19 patients? Dr. Sheila, very important question. We have displayed the slide.
Regional anesthesia.
It's always a spinal anesthesia or a preferred
epidural. Regional.
Yes.
And Niranjan, the other question was whether HIV gowns to be used in the ward rounds. So
no, madam. No. What we have done is we have got now actually those patients who are coming in labor ward, we do not know whether they are positive or negative. So we have got say 20 to 30 patients. So in your nursing home, you have got 5 or 6 or 10 patients. Those are symptomatic. You will be wearing a PP, as I said, we will be doing in 3 duties, 8 to 4, 4 to 12 and 12 to 8. So you have at least one senior, one faculty, one senior person, one second year, one third year and one first year. What is important is that when you have got 2 or 3 symptomatic patients, you need to send their swab. That report will come next day or day after. Till that time, you will be wearing a PPV. When she delivers directly, you will not transfer her into a PNC ward. Okay, you will be keeping it in an area which is designated to be suspected cases because they are symptomatic. Remember that asymptomatic patient, if you transfer them in the PNC ward, that can also be COVID positive. So initially we used to do testing of all the patients. So that is a drawback. So when you get the result which is positive of a swab, we then shift her from labor ward number 12 from the holding area, holding ward, we shift them to the COVID ward. And then you manage her accordingly as a COVID patient. They could be asymptomatic or symptomatic. And the rest of them who are asymptomatic, they are shifted on to the other ward, which is the normal postnatal ward. And that is what we are worried, because as per the guidelines, this is where it can spread from one to another. So even now when you are visiting that ward, we always wear a PPE, one faculty, one senior resident and one junior houseman. So 3 people, when they go for morning rounds, they finish the antenatal ward, the labor ward, the postnatal ward. Then you go to the COVID ward. You don't go from COVID ward to the other wards. See, you have to understand all these things. So you have to go from the least area to the worst area. So these are all.
Niranjan,
yes,
when we were actually postgraduate, remember we used to have a septic case. So what
yes,
was the
yes.
first you finish the operation theatre, then you finish your routine, then last you go and do your septic work.
Yes.
Same dictum you have to
now, as you said, madam, you're right that septic OT is now COVID OT.
Yes.
Yes.
OT,
we have one separate OT too.
Okay, I think time has come to say bye-bye now.
Thank you.
Yes, ma'am.
Bye.